Hello, everyone. Hope you can hear me. I'm glad to be back. Uh, uh, Updates in metastatic breast cancer is what I'm going to talk about the next 30 minutes or so. So basically, always important to begin by reviewing the biologic stages of tumor development in breast cancer, how breast cancer starts from one malignant cell that proliferates, divides, up to a point where it gets its own blood supply. And after that, these cells start invading the bloodstream and going to other areas, and this dissemination to other areas and organs is what we call metastasis or cancer spread. Clinically, stages of invasive breast cancer are roughly divided into these 4 stages. Stage 1 disease is cancer that is clinically confined to the breast itself. Stage 2 disease is when the cancer has appeared not only in the breast, but now also in the regional lymph nodes. And stage 3 disease in the breast and regional lymph nodes, but now has more advanced features. So it is invading the skin or the chest wall, the muscle, or going to the internal mammary lymph nodes, kind of a deeper station. And of course, stage 4 disease is when the cancer is clinically present in other organs such as the lung, liver, or brain. Of course, what we aim to do in stage 1, 2, and 3 breast cancer is to try to predict and preempt micrometastatic disease, cancer that we don't see yet, but that if left alone, it can grow and become visible disease, and thus stage 4 disease. So what we do in stage 1, stage 2, stage 3 disease is give adjuvant therapy, whether it's chemotherapy, anti-estrogen therapy, or biologic therapy or antibodies, to try to prevent macrometastasis from developing into actual clinical stage 4 disease. When we look at metastatic breast cancer clinically, still the approach depends on biomarker status. And the key biomarkers are ER, PR, and HER2. And ER and PR is what we collectively refer to sometimes as hormone receptor positive breast cancer, HR positive breast cancer. Then there is HER2 positive breast cancer, which is a key driver of growth and survivor for a cancer. And a group of patients will have HER2 positive and HER positive. So it'll be ER positive, HER2 positive breast cancer. So you have dual targeting potential there. And then, of course, you have breast cancer that does not have ER, PR, or HER2, which is what we refer to as triple-negative breast cancer clinically. The backbone treatments for the different cancers is different. There's more specific and increasingly becoming more and more specific. For hormone receptor positive breast cancer, blocking the estrogen receptor pathway with or without targeted therapy, and then using chemotherapy when cancer becomes resistant to these strategies. That's the backbone approach. For HER2 positive breast cancer, monoclonal antibodies against HER2 are the key backbone. And now more and more these antibody drug conjugates, which deliver a chemotherapy payload inside HER2 positive cells, is an increasing availability option. And of course, then there are these smaller inhibitors of HER2, like tyrosine kinase inhibitors, which we'll go over them a little bit. And these are another class of drugs. And we use any one of these essentially, except for the drug conjugates, in combination with endocrine therapy or chemotherapy, depending on the clinical situation. For triple-negative breast cancer, chemotherapy has always been the backbone of treatment, but more recently, there have been significant advances in the use of immunotherapies, targeted therapies, and also drug conjugates there that we will go over some of these recent advances today. It's very important to go over the objectives of treatment for metastatic breast cancer at the beginning with patients, and visit that regularly during the course of treatment and as things change. And this is important because it defines the approach and helps address expectations and define them from the beginning. So improving quality of life and reducing symptoms should be a primary goal of treatment. That's, of course, not always needed because some patients have very minimal symptoms. So what we would want to make sure of is to preserve quality of life. We should not make the clinical state of a patient, quality of life, worse by chemotherapy or by treatment, especially if somebody does not have much symptoms. It's very easy to make them feel sicker. Then, of course, preventing disease progression is the most important objective, as long as we can preserve or improve quality of life. And improving survival, while not necessarily studied or proven in all treatments that we use, it is largely intuitive in a lot of situations where if we prevent disease progression, we can improve survival as a consequence. Let's first talk about HER2-positive breast cancer, and I'll show you this little cartoon which shows HER2 as a cancer cell surface receptor that is a part of a family of receptors that drive growth. There's HER1, HER2, there's 2 of them here, HER3 and HER4, and basically they all collaborate to some extent to induce cancer cell proliferation, migration, and make it survive and continue to flourish. And the way we target HER2 and stop these processes is by a variety of antibodies. These are the ones that are outside the cell. Of course, Herceptin or Trastuzumab is a classic. Then there is TDM1, which is a drug conjugate that's a Trojan horse that delivers a chemotherapy payload inside the cell. And then there's Pertuzumab or Perjeta, which has been a major advance as of recent, plus several other ones, DS8201, which I'll cover a little bit today, and Margetuximab, which I'm not going to talk about today. I talked about last time, but may not have been as promising as some of these other newer drugs. And of course, then you look inside the cell, there are some inhibitors that go inside the cell, tiny molecules like Lapatinib, Neratinib, and Tucatinib. And Lapatinib has been the prototype, and now Neratinib and Tucatinib are to a larger extent showing more efficacy and an increasing role, and are actually FDA approved for treatment of metastatic breast cancer. So I'll talk about Neratinib a little bit, starting from the inside of the cell. And this trial called the NALA trial in the 3rd-line setting looked at replacing Lapatinib, which is the classic older inhibitor, with Neratinib, and the combination is with chemotherapy using Capecitabine, which is an oral chemotherapy drugs. And this is in a later line of treatment, so patients have already had 2 or more treatments of HER2-directed therapy. And the NALA trial showed, and this is the progression-free survival curve, that there is a significant improvement in the blue line here from using Neratinib instead of Lapatinib, the gray line. And let me just kind of go over quickly. These are median. So what we look in progression-free survival, these usually are the primary endpoints of these trials. And we look at the median, which is the 50% point, at which the 50% of patients experience disease progression or events related to disease progression. And you can see how if you want to just kind of follow through at 50% or 0.5, you move the line and it crosses right around the time where you expect there is any correlation or difference between the two arms, the two groups. So kind of like around here, but you can also look at the line when it's above and you see a space between the two treatments, you know that this is more likely to be an effective treatment. So this shows that this drug Neratinib appears to be superior to Lapatinib based on this data, and it actually has been FDA approved for use in patients plus Capecitabine. Another drug that's very interesting that's more recently approved is Tucatinib, and this is data from patients who received Tucatinib plus Capecitabine, so the same chemotherapy pill as Neratinib, but this time add Trastuzumab. So it's dual anti-HER2 therapy plus the Capecitabine. And you can see the lines that in green and blue that are going below the 0%, how much there is activity, shrinkage basically, and stabilization in disease. And up here as well, anything that exceeds 20% is when the treatment fails, but below that, the treatment is actually effective. And the cool thing is that this focused on including patients with brain metastases because of the idea that these smaller pills can cross into the brain and help brain metastases there. And basically, subsequent to that data, patients with HER2 positive metastatic breast cancer who prior received HER2 targeted therapy, they received Tucatinib added to Trastuzumab and Capecitabine and compared with placebo plus Trastuzumab and Capecitabine. And looking at the data, there was a significant improvement at 1 year with the addition of Tucatinib over placebo, 33% versus 12%. And this is the graph, which basically shows that there is a significant improvement. Again, you see the blue line in this randomized trial moving, separating from the red line, and the degree of the percentage of patients who are alive without disease progression at 1 year here versus here. So 33% versus 12.3%. So clear and effective therapy. And Tucatinib in heavily pretreated HER2 positive metastatic patients, including those with brain metastases, can improve overall survival and progression-free survival, and has actually been FDA approved as well. The main side effect, like Neratinib and all these, the pills especially, elevated liver function, risk of diarrhea, which can be significant and impact quality of life, and hand-foot syndrome. If you've ever taken Capecitabine or Xeloda, hand-foot syndrome can be increased or worsened with the use of Tucatinib. Another drug that has recently been approved for HER2-positive breast cancer is like TDM1, which is a drug conjugate. It shows quite a bit of activity in patients. And again, you see this impact by looking at a drop in tumor volumes, quite a bit of drop. And also interestingly, in a small number of patients with low HER2 expression, not the classic HER2 positive disease. And this drug has actually also recently been FDA approved, and showing efficacy became an available option. So for HER2 positive disease, the outcomes have significantly improved, not just in the early disease setting, but in metastatic disease setting, and further improvement with the addition of several new agents that are now approved. I, of course, did not talk about TDM1 and Pertuzumab or Perjeta because they already are there, approved, and very effective in first and second line. We always have to take into account the cost and toxicity when using these treatments, especially with the pills, the risk of diarrhea and hand-foot syndrome with Tucatinib. And we're still studying resistance mechanism to see what eventually leads these drugs to stop working. Now switching a little bit to the next subgroup, ER-positive breast cancer, which is the most common group of patients with metastatic disease. About 70 to 80% of all breast cancers express the estrogen receptor. That's close to 800 or more thousand patients worldwide. It is responsible for the majority of metastatic disease, and anti-estrogen therapy or endocrine therapy is important because it's relatively inexpensive, mostly pills, non-toxic, and definitely achieves our purpose in terms of preservation of quality of life, especially in metastatic patients, and has resulted in major improvements in all disease settings in ER-positive disease. The different ways we can block the estrogen receptor pathway, selective estrogen receptor modulator or SERMs. Tamoxifen is the classic drug. It's been there for a long time. Then we have selective estrogen receptor downregulators like or SERDs like Faslodex or fulvestrant, which degrades ER. And now there are several oral forms of this that are in development still. Estrogen deprivation modalities, of course, like aromatase inhibitors, with many are familiar with, that we use in postmenopausal women, and of course suppressing the ovaries or ablating the ovaries or surgically removing the ovaries that causes estrogen deprivation in premenopausal women. And then there are other modalities that we still use every now and then, but their use has diminished with newer advances in anti-ER therapy. Some of these, like using progesterone, high-dose estrogen, and androgens, have not been as prominent recently, but still have a place. The key is that even though all endocrine therapy has improved substantially, the major problem is still resistance. And eventually these pills stop working, and finding ways to overcome resistance is critical to prolonged benefit. This cartoon shows where the mechanisms of resistance may lie in a cancer cell. Remember, estrogen receptor is inside the nucleus versus HER2, for example, which is on the membrane, it's outside. And the way the signaling works through transcription or creating proteins that lead to growth, metastasis, and angiogenesis, we can block this process by using anti-estrogen therapy, whether taking away estrogen or blocking the estrogen receptor itself with tamoxifen or Faslodex. And that's been very, very effective. But in the recent years, we have increasingly been using this other class of drug called CDK4/6 inhibitors, which basically, to me, is not as much a mechanism of resistance as it is optimization of the inhibition effect of these medications that we use to block ER by further enhancing downstream blockade and creating a more effective boost to the use of these anti-estrogen treatments. So these have been a major advance, and there are several of them in development that have been through several trials, each in metastatic disease, and also now in the early disease setting. Palbociclib, ribociclib, and abemaciclib, the three drugs that are available. And I'll just do a highlight here. This is a little bit old now, but you can see how the addition of palbociclib to Faslodex in second line, so these are aromatase inhibitor resistant cancers, you see how there's a significant prolongation of time to failure, blue versus red. And in this other study that I like to highlight specifically because it's done in premenopausal patients, so ribociclib significantly improves progression-free survival in patients who have metastatic disease, and premenopausal. So you block the ovaries and give tamoxifen or an aromatase inhibitor, doesn't matter, and you give them ribociclib, CDK4/6 inhibitor, and you get a significant improvement, not just in progression-free survival, but we know also now overall survival is impacted. And this drug, of course, is FDA approved. So that's one way of targeting resistance to anti-estrogen therapy. Another way, if we want to improve the benefit of blocking estrogen and the estrogen receptor, is by blocking this other key survival signal downstream of surface growth and survival receptors. It's called PI3K pathway, through inhibition of a mutation called PIK3CA. And this study, as an example, shows that if you give an inhibitor, this drug called alpelisib, to patients who are receiving Faslodex and have not just ER positive disease, but also they have PIK3CA mutation, you achieve a significant improvement in a progression-free survival. And you see the separation in the lines here. And this drug is also FDA approved and available for use. And you would have to test the tumor for PIK3CA to know that it is present. And always important to consider a biopsy when cancer progresses beyond first line, if there's new disease, and you want to consider new therapies, to consider doing a biopsy to look for this mutation if that is a possibility. So these are just highlights of some of the changes in ER-positive breast cancer. And as a summary, the idea of targeting the estrogen receptor as an isolated pathway may not be optimal anymore. So we know it interacts with other signaling survival pathways in a cancer cell, and you may have to inhibit those as well to improve therapy and reverse resistance. So combination with other targeted therapies, like CDK4/6 inhibitors or PIK3CA inhibition is becoming increasingly used. We have to be careful about toxicity, because targeting estrogen alone is not the same as adding these pills, which have a risk of side effects, and that, sometimes we overtreat and we may cause quality of life issues. So we have to keep that in mind as we balance benefit and side effects. A lot of patients may actually, depending on the clinical situation, benefit from using just anti-estrogen pills in the first line of metastatic disease. And there are certain criteria that can be used clinically to determine that. And then you can reserve these other targeted therapies to second line when resistance develops. And you may have a higher value from using your cards one at a time. Now, going to the third group of metastatic disease, triple-negative breast cancer. And this is disease that has no, by definition, ER, PR, or HER2. So that's why I call it triple-negative. It's about 10 to 20% of all breast cancers. These patients tend to be younger at diagnosis, and it has a higher risk of mortality because there's no target, and we treat, and there's a high risk of failure in patients sometimes because we just don't have a good way of knowing using a target that could be a predictor or of treatment response or a prognostic variable. So it's one of the more aggressive cancers, and chemotherapy has been the backbone treatment for these patients, and any number of chemotherapy schedules. More recently, immunotherapy has become a significant addition. PD-1 or PD-L1 pathway. This is basically a signal that tends to protect cancers to evade the immune system. And if you block this signal, you can unmask the cancer cells for the immune system to go after them. So basically, it unleashes the immune system against the cancer cells, and basically is a way to control, attack the cancer and can be very, very effective as long as there is expression of this receptor present. And the classic trial that we know now, and based upon which this drug called atezolizumab has been approved in combination with nab-paclitaxel, it showed that there is a significant prolongation in progression-free survival, and overall survival is quite a bit prolonged in those patients with PD-L1 positive disease. So if PD-L1 is not positive, it's not the same kind of effect. Of course, whenever we use any new treatment, there are side effects, and for this particular class that unleashes the immune system against the cancer, it can also unleash the immune system against certain organs. So a lot of issues and immune-related side effects related that include inflammation of a lot of organs, a lot of pneumonitis, inflammation of the lung, liver inflammation, gut inflammation, inflammation of endocrine systems, brain inflammation even. So these can be significant side effects that we have to keep in mind when using these treatments. So the immune therapy is a major advance in triple-negative breast cancer. Another advance that has been there for a couple of years now is using PARP inhibitors, such as Olaparib, in patients who have BRCA mutations regardless of whether they are ER positive or triple negative. But more important, of course, in triple negative, because these patients didn't have as many options as ER positive patients. And when you give Olaparib and compare it to chemotherapy choice, whatever choice a physician wants, and compare the two, what you find is that Olaparib also has significantly improved progression-free survival over chemotherapy du jour, if you want. So chemotherapy of any kind, if somebody has BRCA positive metastatic disease, whether they're ER negative or ER positive, there's a significant benefit from the use of Olaparib. And these, again, are patients with BRCA mutations. This is another drug, a drug conjugate, a Trojan horse, if you will, that has also been recently shown to be quite an effective approach in patients with triple-negative metastatic breast cancer that's refractory to treatment, and it was found in a basket trial, meaning a trial that's looking at whatever marker and using marker specifically for those patients, but in triple-negative disease. This Sacituzumab drug conjugate in a single arm study of about 100 patients showed a significant response rate of 33% in a median time of progression-free survival of 7.7 months. That's quite significant. It caused diarrhea and some cytotoxic effects, but this is like a bone marrow toxicity, but it's quite a bit of benefit for this type of disease. And you can see that in this non-randomized study. And sometimes when you need treatments that are effective, drugs can't be approved without having a randomized trial, basically, because there are no other effective treatments, and you show this promising activity. And here, again, you draw the line from 0.5, the 50% mark, you go close to 7 months basically of benefit. I want to talk a little bit about tumor profiling and targeted therapies, things like foundation medicine. They are used frequently. Just want to caution that other than a couple of significant targetable mutations, PIK3CA is one of them, the one we saw earlier. Sometimes HER2 mutations, very rare, but when you find them, you want to act on them. There's not a lot of bang for your buck. So you do these studies, but there's a lot of emphasis on actionable or targetable mutations, but they actually are not. We don't really know how targetable they are, and the benefit is usually low. It is something that we use when you're looking for new target, and there's still always ongoing trials. They are useful to identify targets for a clinical trial, but in practice, I would say it's more of an added approach, but not necessarily a very effective approach. It's useful if you find some of these mutations. So to summarize, in triple-negative breast cancer, there's been significant advances with the immunotherapies, PARP inhibitors, drug conjugates, but many ongoing trials. Tumor profiling is significant, at least for clinical trial purposes, to identify new targets and test new therapies. Chemotherapy is still a significant use and still a backbone therapy for most patients. And I can't emphasize this enough. The clinical trial participation in metastatic triple-negative breast cancer is something that every patient should consider, more so even than ER positive and HER2 positive. Always good to look for new options, novel therapeutics, because we know that treatment is limited in a lot of patients. Something to mention here, neoadjuvant versus adjuvant. So in early stages disease, phase 1, stage 1, 2, 3, we had talked about the potential for metastatic disease. You really are kind of shooting in the dark if you do surgery first, remove the tumor, and then give chemotherapy, and then wait to see what happens. Ideally, the majority, if not all patients with triple-negative breast cancer should get neoadjuvant treatment before surgery in the early stage setting. So you treat them first while the tumor is in place, and then you do surgery. If it's gone, that's great. If it's not gone, then you can retest it, you can follow, and you know what to expect down the road. So always think of that possibility of using neoadjuvant treatment versus surgery first, especially in triple-negative breast cancer. Of course, I always like to quote this slide that, and we're not always talking about only benefit of treatment. We have to calculate cost and toxicity, quality of life to come up with value. So not all treatment that shrinks cancer or keeps it down for longer has the same value, because you really have to think about quality of life issues and whether this is feasible or makes any sense. So you always think of the value of treatment rather than just the benefit, especially with our goals of treatment that really needs to preserve or improve quality of life. So to conclude this talk, it's always a good idea in metastatic disease to consider second opinions when you're looking for what's the next treatment option, or when you are charting a path for what to do next. Always good to get fresh set of eyes, especially breast cancer expertise matters if you're being treated in the community by a general practitioner. Always good idea to biopsy new disease to look for targets, see if there's any change in disease status that will minimize the chance of you shooting in the dark or just using the next treatment option blindly. Clinical trial participation is critical, especially in triple-negative, but where always where available is a good idea. There are new drugs that are available every year, so always good to stay up on things and stay educated and connected with your physicians. Metastatic disease is not a black and white or a little black book. It's a mix of science and art, and every patient is different. So it's very important to have expertise in how to select and how to manage treatment, and how to manage expectations around treatment. Quality of life, of course, cannot be overemphasized. More life to live is something I like to say. It's not just the numbers, but also quality of life is very, very important. And in that context, less can be more, and vice versa. More can be less. So more is not always better. And sometimes you can, if you're a minimalist in your approach, you can preserve quality of life effectively. If there's anything I can ever help any patient, please feel free to email me, contact me, whether about this presentation, about any other drugs, or about your case specifically. I'm always happy to help. And with that, thank you, and I'm happy to take any questions.
Okay. Let's see. Can people hear me? I don't know if they've put me live or not. Nope.
So should I go over
yeah.
the questions that I see in the chat and start answering them, perhaps?
Yeah, can you hear me, doctor?
Yeah, I can hear you.
Oh, great. Okay. Hi, I'm Amy. I've been monitoring the questions. So thank you so much for that
oh, no
presentation.
problem. No problem. Yeah.
And yeah, I'll just help you start out with those and just reiterate that we may not get to all of them. So thank you so much for your
I'm happy for patients to contact me anytime. Yeah, so share my email for sure.
Wonderful. Thank you.
So should I go through some of these here?
One question. The first question was asking about treatment options or promising directions for metastatic breast cancer.
Yeah, metaplastic is a funny beast. It's very rare. It is typically triple negative, but it may have a different biology. There's a lot of data about profiling it, but there are no real new exciting treatments on the horizon. It's one of those that if possible, treating while it's still present in the breast with neoadjuvant therapy can be helpful in assessing response while the tumor is in place. But no major advances in metaplastic. Always good to get a second pathology opinion to make sure that's what we are dealing with when dealing with metaplastic breast cancer. But it does tend to be chemotherapy resistant, unfortunately.
Thank you so much. The next question asks if you've been treating for many years. This person asks about Herceptin plus Perjeta, and there's no indication of recurrence. At what point is resistance expected? Is it advisable to proactively change treatment before recurrence?
Great question. So this is something that we have been seeing more and more with the advances of anti-HER2 therapy. Patients are on treatment for 3, 4, 5, 6, 7 years, and with no evidence of disease. So that's great. Some of that may be a change in the natural history of disease where it may not come back, but we never make that assumption. This becomes a clinical judgment. So between the physician and the patient, if the cancer hasn't been back for 6 years and there's no evidence of cancer on scans, it's reasonable to consider stopping and watching because you may actually be done with this and may not come back again. There's a comfort level. I'm maybe more comfortable stopping sooner than maybe others where they, and of course the patient's input here is very important because sometimes patients are not comfortable stopping, they may want to continue. So this is a conversation between the physician and the patient, and it is a clinical judgment, but it's very reasonable to consider stopping therapy when there's no evidence of disease and it's been years. Otherwise, you're just getting treatment endlessly, right? So this is something to keep in mind.
Well, and on that note of monitoring techniques, so what are there recommended frequency of PET and CT scans or checking PA27, 29, that sort of thing?
Right. So scans, especially for this patient, looks like, if cancer has not been back for a while, every 6 months frequency is appropriate. That scan is fine. I'm not a big fan of CA27, 29. There is clear guidance from the American Society of Clinical Oncology that discourages the use of these markers because they create anxiety, and bumping up or down is not really going to change decisions about treatment. Radiologic disease is more critical. So I would advise against using serum markers for monitoring disease, CA27, 29 being one of them.
Okay, thank you. So we're watching time. I think you meant Oh, go ahead.
Oh, no, I see the next question. You can ask if you like. And yeah.
So this was about bone-only metastatic breast cancer and going off hormone or targeted therapies if there's no disease progression over time.
So it's a little bit different because, like I said earlier, pills, anti-estrogen pills especially, they're easier to take. And if there's no side effect or toxicity and the cancer is stable, you continue them open-ended. And lots of patients with ER-positive breast cancer, because of the nature of the disease being so slow-growing and indolent, it's not going to grow for a long time. But you don't stop treatment; you just keep going, even if it's been stable. For targeted therapies, it depends. It depends on toxicity because they add toxicity, and clinically, you just have to kind of think whether we need to continue with targeted therapy. Imagine somebody who's been on 3 years of combination therapy with an aromatase inhibitor and palbociclib, for example. Did they really need to be on palbociclib as well? I mean, that adds toxicity and adds cost. That patient may have been just fine for the next 3 years without this addition. So again, it's a clinical judgment to consider, but definitely for hormone therapy and estrogen therapy, it's a relatively easier decision to continue therapy without progression because of the nature of the disease.
Great. Have you seen COVID slowing down the metastatic breast cancer trials or research progressing on?
So overall, COVID has reduced breast cancer patients and cancer patients in general, whether it's treatment, whether it's clinical trials. We don't know the full extent of this, but it certainly has been a factor. And we will see what data comes out as we follow with outcomes from the pandemic. But no doubt that at least the last 6 months since the shutdown, there has been a significant curtailment of clinical trial and treatment activity for patients.
And one person asked why we can't use immunotherapy to treat earlier stage 1 through 3 breast cancer.
So great question. There are clinical trials, and some of them are showing promise, especially in triple-negative disease in the neoadjuvant setting. It's not yet a standard of care. So that's why clinical trials are important. And I would encourage any patient, especially patients with triple-negative disease, to look at clinical trials in stage 1 to 3 disease that they may be eligible for, to consider enrollment in these clinical trials. There might be some advances in there as well, but as of now, it's not a standard of care. It is a clinical trial option depending on the institution.
Great.
There's a comment, looks like.
Yes, a comment, thank you very much. A comment saying, very interested in your work to get treatment to those without resources around the world.
So I'll say this and explain a little bit. I appreciate the comment. So basically, most patients with breast cancer, and I'm talking about breast cancer specifically because that's my area of expertise, they get treated in community settings. They could be anywhere in any country. There's no breast cancer expertise, and they don't have access to get a second opinion about how best to approach their treatment. And this day and age, with the digital revolution, there's absolutely no reason for patients to be connected to experts from anywhere to get second opinions or to maintain a contact to when things change, to influence their treatment locally. So this is a form of patient empowerment. And we do want to empower patients to seek those second opinions, and regardless of geography, regardless of where they are. So this is really very important because anybody anywhere deserves to get the best access they can for whatever treatment they can get.
Great, thank you. And then there's so much information in all of this. Will the slides be available after?
Yeah, of course.
Okay.
Yeah, no problem. I'll actually just go ahead and email it so that you guys can have it and you can share it with patients. It will have my email on there as well.
Perfect. Okay. Oh, one more.
There's one more question.
Your thoughts on cancer, added sugar, and proliferation of cancer cells.
Okay, so this comes up a lot. So, when we talk about diet, and this is my advice to patients, it is important to maintain a healthy, balanced diet that includes all food groups. So that includes carbohydrates, includes protein, vary your sources of protein, vegetables, vitamins. don't restrict yourself necessarily. I would hate to think that a patient who would like to have a slice of cake or a cookie that they can't or they don't want to because they're worried about the cancer. That is not the case. We don't treat cancer specifically by stopping sugar. It's good to have a healthy diet habit. Exercise is very important. A healthy balanced diet is key, but do not deprive yourself from certain subgroups. If you like to have that cheesecake, of course you can have that cheesecake. If you want to have that steak, nobody's going to have a steak every day or a cheesecake every day. So there's no truth to eliminating sugar from your diet.
Great, thank you. And this will have to be our last question. Someone asked about you mentioned getting second opinions in general, but they asked about second opinions on pathology. Do you recommend bringing slides to a different institution?
Yeah, and there are processes for this. So let's say there is a question, for example, on metastatic cancer that came up earlier, certain kinds of pathologies, whether there's invasion or not invasion present. These, the slides go to a different institution. It has to be arranged through your treating institution to get second opinion on pathology. It's not as common as clinical second opinions, but it's something that sometimes would be advisable.
Great. Actually, we can maybe squeeze in one more.
Sure.
Can you discuss checkpoint inhibitors in hormone-positive metastatic breast cancer?
So the data has not been as great with metastatic hormone receptor-positive breast cancer. There was some early promise in a phase 2 trial, single arm, a more recent study combining immunotherapy with eribulin in metastatic ER-positive breast cancer. It was just published in JAMA Oncology, and it's negative. ER-positive breast cancer, a little bit different biology. They have not been as useful, and there is no standard of care to use them in patients with ER-positive disease.
Do we want to try to squeeze in one more?
Sure, I can squeeze. I can keep going. So caffeine. I drink coffee, and I think having a cup of coffee is fine. There is no. There's some data in epidemiologic studies, weak correlation between development of breast cancer and excessive caffeine consumption. Stronger data with alcohol. So I say it's okay to drink coffee in moderation. It's okay to drink alcohol in moderation for patients whether metastatic or not metastatic. So there's it is not not something to deprive yourself from. Is that all? And then thank you so much, Judy.
Thank you so much for your time, Doctor. I want to let everyone take their quick 10-minute break, but thank you so much. We really appreciate it. And as soon as we'll make your email available, and we also encourage people certainly to feel free to contact
me anytime. Absolutely.
Our education specialists as well. And then we'll take a 10-minute break.